Take a seat. So the surgery is going to be starting in about 20 minutes, 25 minutes. I thought usually in these events you get a lot more from it, from, as I said, learning from each other and learning from people from other countries, other specialties. What we'll do is I'll just do a quick hello and introductions, and then I want to go around. I want people to say who they are, what their role, whether they're with Molnica, whether they're surgeon, HCP, etc., and what they do in terms of their specialty and what they are trying to get out of the next day. It's not like a test, all right? So whatever you say, you can still stay till the end of the day, all right? So we'll start with an easy one. So obviously I said I'm Abtin Alvand. I'm a knee surgeon. I'm director of the hip and knee unit in Oxford, and I've worked with Molnica a lot on negative pressure dressings. I've used lots of different negative pressure dressings as well. My work revolves around infection and revision knee replacement, and my research revolves around that. And I come to Istanbul a few times, and I love it. It's very nice. Sinead?
Thank you. Hi, everyone. My name is Sinead Fahy. I lead the professional affairs function for Munlica. I'm Irish, and I'm very happy to be here today. And what I'm hoping to get out of this is loads of feedback from you guys about our educational programs, what we can do better, what will be exciting for the future, and all feedback is welcome. Sorry? Yeah.
I'm going to introduce one person who's not going to talk now, Dr. Ida Miadfar, who's the director of the International Joint Centre. She's going to speak at the end of the morning and talk about what she does here, what the International Joint Centre is about, and how you can get in touch if you want to have any contact with them here. Okay, so Ida, you can't talk. Right, okay. Next.
Yeah, okay. Hello everyone, I am physical therapist Burcu Kocabey. I'm working for IJC and also I'm working here for 18 years. Yeah, with my team. Thank you for coming.
Good morning, everyone. I am physical therapist also. We are working together and also with Dr. Parvizi. Also, we have been working here 19 years. Thank you.
Very good. See, it's easy.
Good morning, Danny. I am a lower limb surgeon and I work in France. I do a lot of total knee, total hip replacement and knee arthroscopy. And recently we started with robotic surgery, the total knee.
Hello everyone, so I'm Joran Chancrin, I'm Clinical Engagement Manager for France, and I'm really happy to host you here, and I hope you will enjoy the day. So, welcome.
Hello, my name is Pasha. I am head of the orthopedic department at the Copenhagen University Hospital. We do mainly reconstructive surgery, revision surgery, but also unis and primaries and robotic surgery.
My name is Klaus. I work with Pasha and do knee arthroplasty revisions and infections. Yeah.
Few latecomers. So just introduce yourself and what you do.
Yeah, good morning everyone. My name is Firas Spail. I work in National Guard for Health Affairs in Riyadh. We do primaries and complex arthroplasty surgeries.
Good morning. This is Hadi Geshgari from Saudi Arabia. I'm medical rep for Moleki.
No problem. By the way, we did not arrive late, but we were following the schedule. Ali Liami from Saudi Arabia. So I am in King Abdulaziz Medical City, which belongs to National Guard. We do musculoskeletal oncology and major limb reconstruction in terms of hips and knees, primary and revision as well.
Good morning, I am Slimani, Assistant Consultant, Orthopedic Oncology and Reconstructive.
Hi, my name is Jędrzej. I'm coming from Poland. I'm orthopedic surgeon. I'm working at the university hospital in the middle of Poland.
Yeah. Hi, my name is Bartosz. I'm also from Poland, but from the different university. So I'm a knee surgeon, and I do a little bit of boring hips.
Hi, my name is Monika. I work with Monlika as clinical specialist in Poland.
Hi, my name is Ellie. I'm a clinical specialist for the UK team at Monlika. I'm looking forward to kind of using today as a bit of a springboard to do some more educational opportunities in the UK.
I'm Rob. I work in the London and South of England team for Incision Care, so supporting with advanced limb-flex border post-op, and yeah, look forward to seeing how it gets used today, and hopefully bringing some discussions later in the day.
Hi, I'm Hayat Khan. I'm a hip and knee surgeon from the UK. I do both trauma and elective, but have a particular interest in periprosthetic fractures. I'm hoping to get a Molnica branded T-shirt like Rob, with really tight arm bits to show my biceps.
I'll tell you something interesting. Hayat also managed to get himself a tailor-made suit made yesterday in Istanbul. So
I'm wearing it. Actually.
Very nice. It looks good.
Okay. I prefer more of a loose-fitting T-shirt myself. Hi, my name's Carl Green. I work at the Golden Jubilee National Hospital in Scotland. I'm the revision lead and deputy clinical director, and we focus on lower limb arthroplasty, and I do revision knee and some hips too.
Great. I know, Chris, so stop there. We'll come back to you. They're about to start in theatre, so we are going to get going again, and we're going to go around the whole group again. I just wanted to introduce Professor Tunçay, who is one of the directors here in Acıbadem University Hospital. I told you about him yesterday. He's just going to say a few words, and then we're going to go to theatre.
Thank you very much, Roland. Good morning to everyone. Welcome to Istanbul and welcome to Acıbadem Maslak Hospital, Acıbadem University. We are too happy to see here all of the countries from 15 countries, isn't it? And 15 countries, more than 60 attendance, faculty, colleagues. Thank you very much. And probably you might have come to Istanbul before that. First one? Very good. And Acıbadem University is one of the elegant universities of Turkey. And we have established in 2024, together with Professor Cihat Parvizi, Professor Remzi Tözün, and sorry, I'm getting old. I forget the names. Next time I will forget my name. Semih Tarabici. I'm so sorry. I'm Semih Tarabici, and that's Remzi Hoca is here, but Semih Tarabici is not in Dubai. And we have done very good educational activities. As you know that, one of them is in 2024 World Expand meeting, and in 2025 the third international consensus meeting of infection. Maybe some of you were there. And thank you very much. Especially I would like to thank the Elvent, very good faculty from Oxford University. And Professor Parvizi is still finishing the first side of the patients, and we will start the second one, and we will discuss. We have a very good program, a very good event together with you. And if you need anything, please don't hesitate to contact us. Also, we would like to thank the Molnike companies, the CNET. And their good support, very good support, very generous support. We would like to host you, all of you, and thank you very much, and hope to have a good event. Thank you very much.
We'll see you soon. Okay, are they? They're ready?
Yeah.
Hi, Jay. How are you? Can you hear me?
I'm doing great. Yes. Can you hear us?
Yes, we can. We can.
Right. So yes, if you can focus on me, perfect. Hi, everybody.
Just one second. Okay, we're on. Okay, go ahead. We can see you.
Perfect. Welcome to Istanbul. Welcome to Acıbadem. You just heard from Professor Tunçay. It's a wonderful opportunity for us to have you here, everybody. I'll be there in about an hour. So today we are, thanks to Molnlycke, having an educational program where we will share with you our infection prevention protocols. That's the emphasis of the day, not how to do knee replacement, although you'll get to see conventional knee replacement in a minute. But if it's okay with you, let's start from our infection prevention protocols, and we go from there. How does that sound, Upton?
Sounds perfect. I think, yeah, I think these are the bits that are not that are often overlooked or too simplified.
Perfect. So let's start from the case here. She's a 65-year-old lady with bilateral knee arthritis, tricompartmental disease, and she came to see us about 2 months ago with complaint of bilateral knee pain. Interestingly, she'd had multiple injections. So let's talk about that issue first. If somebody has had an injection into their knee, when do you decide to do a knee replacement? How long do you wait and why? We and others have done some research showing that injection into a knee, whether it's hyaluronic acid or steroids, changes the microbiota of the joint and predisposes these patients to increased infection. And the signal from registries as well as our work suggests that it takes 3 months for that microbiota to return back to normal. Because of it, we do not operate on patients for a minimum of 12 weeks after the recent injection. Hyaluronic acid, steroids. We had a meeting on Saturday here, extensive discussion of all the infection protocols. One of the questions was, what about PRP? We don't have data on PRP, but I would imagine that PRP would also influence the microbiota. So that's issue number one. Any questions there, Upton?
Any question? Yeah,
comments?
there's a question from Chris Key from Scotland.
What about arthrosamid?
What about?
Arthrosamid.
Arthrosamid, have you seen that? It's sort of a matrix that they've injected recently.
Yeah, great question. And unfortunately, Chris, the number of these injections are increasing. There's numerous of those stem cells. Now there's a lot of other stuff that people are injecting. And then the German invention recently that patients keep asking about. I don't have data, but I would imagine that any injection, any intervention in the knee, even arthroscopy, would change the microbiota. And because of it, I would think 3 months, if you can wait, would be best. So this patient has waited for 3 months. I think that's probably the right message to take away today. Now, of course, if it's an emergency, then clearly you can bypass that rule. But in the case of an elective arthroplasty, I think that's the best option.
And I think we're seeing that a lot. Access to healthcare privately is very quick, so patients have an injection. It might not work. They come back and they want a knee replacement the next day. And if you don't do it, they'll go to another surgeon. So we really have to get that message out there. Okay, any other comorbidities, Jay, on the patient?
So this lady does not have diabetes, but let's assume she has diabetes. And let's assume, actually, she doesn't know if she has diabetes. So patients with diabetes, established diabetic conditions, they must have well-controlled glycemia before you operate on them. What do we mean by well-controlled? Well, American Diabetes Association says that hemoglobin A1C level should be under 7%. We did a study, as you all know, from AHKS group, 15,000 patients. And what we saw was that as soon as the hemoglobin A1C goes beyond 7.7, there's an exponential rise in the incidence of infection. So because of it, majority of organizations and institutions are now using 8% as the cutoff. So if you have a patient, hemoglobin A1C is above 8, you should really send them back for better optimization. So how long does it take for hemoglobin A1C to come down? 3 to 4 months. And because of it, we published a paper showing that you could, in those circumstances, use fructosamine that has a shorter half-life to monitor the patient's glycemic control. Level under 295, 300 probably acceptable. The second thing is fasting glucose. So here, Apton, I'll be interested if you ask all the surgeons in the room, who does not do glucose screening prior to arthroplasty?
Okay, let's have a hand. There's a few who don't. Is it to do with your institution's protocol, or there's a couple of surgeons in Sweden, in Copenhagen, in Denmark, who say they don't do that? We're just going to get a comment from them.
Well, fortunately, in Scandinavia, people are extremely healthy. But in places like America and even here in Turkey, 18 to 20% of people are hyperglycemic, and they don't even know it. So it is a good idea to have a glucose screening test. What does that mean? Fasting glucose. But if the patient is coming to the preoperative admission at 5 p.m., you can't really expect them to be fasting from the night before. So in these circumstances, you could do fructosamine or fasting glucose. CDC says under 200 millimole per liter. And I know Europe uses different units. That would be 20. Here at Acıbadem, we do not go beyond 160. Anybody's fasting glucose greater than 160, they go to see an endocrinologist.
That's great. And is it a difficult conversation to have with patients when they come to you and you say that, or do people generally accept it?
That's not as difficult as the next point I was going to talk about, which is smoking. But no, diabetes, I mean, it's a good conversation to have, because if they've got hyperglycemia and uncontrolled diabetes, their risk is so high that you really shouldn't proceed with an elective arthroplasty unless their diabetes is under control. I mean, do you agree?
Yeah,
Anybody in the room
I think that's pretty good. Most patients fairly happy with the emotions of talking about their blood sugar, less so about their weight and their smoking habits. Is that right?
Yes. Yeah.
So let's move on to smoking then. Okay,
So the
sorry.
conclusion on diabetes is you should have a glucose screening protocol. If you can afford it, your institution can afford it, I think it's a good idea to do hemoglobin A1C on everybody. And the level, again, should be less than really a normal non-diabetic should not have a glucose beyond 6.2%. But if it's 7.5, they're definitely diabetic, and they need to know that. And above 8 is a huge risk for PJI. So you should not, and it's not just PJI, by the way. Risk for venous thromboembolism, cardiovascular, neurological, all of these risks increase.
Yeah, great.
Okay, so that's that conversation. Then comes the conversation of other optimization protocols. And if time allows, let's go through those. Is that a good idea?
Yeah, that's good, as long as you guys are still going.
Okay, smoking. We're struggling with that here because majority of people in Turkey are smokers. But really, there should be a smoking cessation protocol, especially for complex revisions, for example, PJI patients for sure. And the smoking should stop minimum 4 weeks, preferably 6 weeks prior to surgery. And if you are going to have a smoking cessation protocol, you should be checking their urine for nicotine.
Yeah.
Because
So
if you
I'm
tell
just
a
gonna
patient-
I'm gonna ask the audience who bans smoking on their patients. Anyone? One group, one person from South London. But yeah, we can't either. I'm trying to introduce it, and again, monitoring it, making sure they say they have, and then they haven't. That's always, and actually the urine analysis is probably a good thing. But it looks like not many institutions in this room are having a smoking cessation program.
Yeah, that's a tough one.
There's one
It's a
question,
very tough
again, one question is coming.
So we have a protocol to try and stop people smoking, but we don't monitor carbon monoxide. We don't monitor nicotine in the urine. How do you get around the ethical dilemma of restricting access to an operation that, even if that patient continues to smoke, is most likely not going to end in infection and most likely going to give them a massive improvement in their quality of life?
That's
Yeah,
go
that's
on,
a
Jay.
great question. I think that question can be applied to all comorbidities, by the way. So somebody with a hemoglobin of 8.1 is not definitely going to get an infection. Somebody who's anemic, etc. I think all of these are efforts to try to minimize their risk. And I think patients should take accountability for their procedures.
And I think,
Because once,
yeah, I
go
agree
ahead.
with you. I think, yeah, there's a few that are difficult to address. So obesity, diabetes, those are difficult. And some patients may have metabolic problems. But I think there's a few things that in my book are lifestyle choices, and that's smoking, intravenous drug abuse. So those are things that you can give support to patients with, but for an elective procedure, I personally think we're within our right to at least limit that resource.
Yeah, but I think that's a great question. And the other is, again, BMI. Do you have a cutoff, 40, 35, 50, whatever? So that, again, would deprive a lot of patients from an operation that helps them. These are philosophical to some extent. But again, here we don't have a BMI cutoff. Well, we definitely have what you just alluded to, Abton, metabolic syndrome. If a patient has hyperglycemia, dyslipidemia, hypertension, and they're obese, their risk for infection is really high. So in those patients, we definitely try to optimize them as much as possible. But we don't have a BMI cutoff. Do you have a BMI cutoff in Oxford?
No, it's an unofficial one. It's 40, but we just generally try and get patients to optimize their weight. So if they bring their BMI down from 48 to 41 and they're generally healthy, then we'd go ahead. But again, we're not allowed to deny access to healthcare, although some surgeons make it a bit difficult for patients with high BMI. Also, it depends on where the BMI is, right? If it's all in the belly, like some men, it might be a bit easier to manage. Whereas if the soft tissue envelope around the knee, for example, is very big, and even the BMI may not be that high, it'll still create some wound healing problems.
Okay, so then is the issues of anemia is another one.
Can I just, there's just two questions, Jay. One in the front, one at the back. Just 1 second. Is that all right?
Yes.
I was just going to ask about GLP-1. I know that it's really taken off in the UK, so I don't know about the other countries, but potentially has as well. And I just wondered what your experience with that is, and what kind of capacity with regards to wound healing, wound infection that has.
That's a fantastic question. GLP-1, all the integrin, the semaglutides, all those stuff, they have become very popular. Some people are on them for diabetes control. Some people are on it for weight control. And believe it or not, in Turkey, a lot of people are taking those without the consent of their doctors. And these are available, unfortunately. So with the GLP-1 agonists, obviously the issue is the aspiration risk during surgery because of the effect of these drugs on the sphincters, the gastric sphincters. These patients are at risk. So American Anesthesia Association has recommended that 1 to 2 weeks prior to surgery, patients should stop taking the GLP-1 agonist. The risk of GLP-1 on infection is unknown. GLP-1s are actually thought to be protective against infection. And with a major manufacturer, that is the manufacturer of one of the GLP-1 agonists, well, actually Eli Lilly, we are about to start a study, a multinational, multi-center, to look to see what GLP-1 agonists do to the microbiome of the gut.
Because they're anti-inflammatory, aren't they, as well?
Yes. Yeah, that's thought to be. That's what thought to be. So before, let me show you one thing, Afton. We're going to come to the we'll come back to the patient optimization, but intraoperative also, there's a lot of processes. One is the use of occlusive dressing. So occlusive dressing, based on numerous studies, have been shown to reduce the risk of infection. I'm happy to share those with you. Why? 3 reasons. One is that the occlusive dressing, this is the occlusive dressing of our choice, Mepilex. It provides a seal around the wound, because in a sterile condition in the operating room, we apply this, and this seal will keep the wound as sterile as possible. 2, prevents any type of outside environmental contact. Patients have very different lifestyles. Some have pets, some don't have very hygienic or clean environment. Some may have urinary incontinence, etc. So outside contamination of the wound is not uncommon. So occlusive dressing will prevent the contamination of the wound from outside environment. 3, this provides a relative hypoxic environment in the wound, and a mediator called HIF, hypoxia-induced factor, increases, causes angiogenesis and fibroblast proliferation. And it actually enhances and accelerates wound healing. So those are like 3 of the most important aspects of it. And then there's a convenience factor. Patient can shower. The physical therapist or a patient's family or somebody else seeing the wound, getting worried, etc., that doesn't happen. This is kept on for 7 days, sometimes 10, sometimes 14. When you peel this off, the wound is completely healed. And the way we close the wound, we use monofilament suture, and we use a monofilament suture that's impregnated with triclosan. Those are the plus sutures.
That's
The
right.
triclosan has antiseptic properties. We don't use the staples. We haven't used staples for a long, long time. And now we show you the wound. Yeah. So now this is under stellar conditions. We will apply this. I let the team apply this Mepilex. And then this will stay on for 7, 10, 14 days. And then we come back. So here you see that. And by the way, the beauty of Mepilex is Mölnlycke's adhesive has an incredible proprietary advantages.
That's right, the
And when
safe
you're-
tack technology, right?
Exactly, exactly. And when you're peeling that off, even on hairy area, etc., no pain to the patient, very easy to peel it off. The obviously the dressing has a silver, but the adhesive itself is very hypoallergenic, very, very important. So you don't get those allergic hypersensitivity reactions that you sometimes see with these patients. So we just apply that. We will now cover that wound, and we're going to show you now adhesive draping. Do you see this? We used IABAN here.
Yeah, we can see the IABAN.
We use them. You don't have to use them, but we use them for 2 reasons. One, because obviously the iodine has bactericidal properties during the surgery. And the second is you can like isolate physically these drapes. If you didn't use them and during the manipulation of the knee, these non-sterile parts could potentially contaminate the wound. So we use this adhesive incised draping. So now we've done with the first side, and I don't use tourniquet. We can talk about this, why not use, why use. That's an ongoing conversation. So now we will cover this. So we did the first side. We just repeated the dose of antibiotics. The antibiotics we give is first generation cephalosporin, 15 milligram per kilogram. And then we are repeating the dose prior to surgery. And because we don't have tourniquet.
Do you worry about
obviously-
penicillin allergy at all?
No, great question. So as you know, in the ICM that was discussed, and the agreement was that penicillin allergy is irrelevant. Patients who have penicillin allergy, they don't have cross-reactivity to cephalosporins, so you don't really need to worry about that at all.
And how long before incision do you start your antibiotics?
30 to 45 minutes.
Yeah.
Cephalosporins can be given fast, but if you're given vancomycin,
It takes a
you
couple
should
of
really
hours.
start that earlier, and we don't usually give vancomycin. But the other is intraosseous administration of vancomycin, which you could do.
Okay.
And as you know, that's been
That's an
described by
interesting
Simon Young
topic, yeah.
from Yeah.
Any
Simon Young and
any extra doses post-op or any role for extended? I'm smiling as I say this.
No.
Antibiotics for a few days, a week or so, or not?
You're
No.
trying to get me angry before we start the day, huh?
Sorry. Yeah. So no role for extended oral antibiotics. What about a single dose?
We give 24 hours, but the data that's getting published now from Duke, that was sponsored by AHKS, and we were part of it, on 3,000 patients, one dose versus 3 doses, no difference in infection.
Yeah, we use a one dose as well.
Gelecek lütfen. Oğlum. Okay. Beni gelecek lütfen. 8.
Yeah, 30 minutes. 30 minutes before, that's it.
Okay, so we
One
double
second,
glove.
Jay. There's a quick question
I think all
from
of you.
1 second. There's a question from the South African colleagues quickly before we go. Yep.
On inductions, do you give cyclosporin before starting the surgery because you're not using a tourniquet?
Because they're not using a tourniquet, are you using
Cyclosporin.
cyclosporin? No, you use IV tranexamic acid, don't you?
We do. We gave 15 milligram per kilogram, which usually ends up being 2 grams. And then we give 5 days of oral tranexamic acid to our patients. We can discuss that during the break. Very, very interesting. It reduces ecchymosis and obviously still continues to reduce the blood clot. So here, after we applied a new drape.
Yeah.
We changed the suction, the pulse lavage, cautery, renewed the intravenous antibiotics. Everything's now brand new. This is a brand new knife. And then what we do here is we are very eager to use povidone iodine during the procedure. So we will start the second side, guys. Can you see it?
Yes, we can. Good view. Can you just comment on the skin prep? Whether you use iodine, chlorhexidine.
So patient has already had chlorhexidine wipes or showers or sponges. Now watch what happens. Professor Tunçay is now applying all this antiseptic to the wound.
So you do that layer by layer.
Yes, correct. And then you will watch our team, you'll watch our team will not touch the wound. We are very, very careful about touching the wound. And the main reason is because your gloves and your hand obviously has, contamination throughout. And anytime you bring the gloves and you touch the wound, you're obviously causing contamination of the wound. So we've now exposed the knee, and we're going to go ahead. Some people say, should you use a new knife? We sometimes do. So we just did our arthrotomy. So we use chlorhexidine. Those brushes? We give those to the patients to take it with them home. And the patients apply that 24 to 48 hours prior to surgery.
And that's for decolonization.
And then with the time of surgery, we're using alcohol as well as povidone iodine and chlorhexidine. We use all of the, so now everything is new knife. And so we make sure the skin comes into contact with chlorhexidine, with povidone iodine, and obviously alcohol.
So whatever you use, so whatever you use, whether it's chlorhex or iodine, it should be alcoholic, correct?
Exactly. So that's and as you know, during the consensus, that was discussed extensively, that we must use. Okay, we usually make a very small incision, but for the sake of today, to be able to see better, let's just enlarge the incision a little bit more. So you can see a little. So now the patient his skin has come into contact with chlorhexidine, with alcohol twice, and povidone iodine. Does that make sense?
Yeah, completely. And what about
Does-
nasal decolonization?
Yeah, we do nasal decolonization with a non-antiseptic, non-antibiotic antiseptic. Yeah. So we're now. Did you see that step? This is very important because the knee and the hip, arthritic knee and hip, definitely have a microbiota.
So you put some dilute betadine down the canal.
We put betadine in the canal. Exactly. So we're trying to get rid of some of that microbiota that the patient has. Every step, people leave irrigation to the end. I think it's a good idea to use the irrigation solution throughout.
Because I suppose you're just trying to tip the balance in terms of the bioburden, correct?
Yes, exactly. Yes. Yeah, we're using this throughout because I think it's very important that we do not contaminate the wound.
I'm just going to ask the crowd, any questions on the skin prep, on decolonization, skin
Yeah,
sterilization?
nasal decolonization, we use the povidone iodine antiseptic.
Okay.
Right, please. We use the povidone iodine antiseptic solution applied 1 hour prior to surgery. That helps extensively. And I think it's a very good idea to do the universal decolonization with the use of non-antibiotic antiseptic. In the old days, we used to use mupirocin, but we can talk about why mupirocin is not a good idea. Because unfortunately, with mupirocin, there are some issues with resistance. There are issues with the application process. It has to be applied at least 7 days, BID. Most patients don't really have the ability to know how to apply it. And unfortunately, what happens is they get suboptimal application. And there is what people call recolonization. But most of us argue that there might even actually be persistent colonization. Okay, so we just did the distal cut. I'm an anterior and posterior referencing person.
So this system's the persona, correct?
This is persona.
You can use whatever system you want, to be honest. There's a question from Hayat.
Can I ask about the foot and what people do with the foot? Do you prep the foot? I know it's a very particular point, but some people will put the stockinette over the foot.
Yeah, so I'll tell you, I think you should prep the foot. I floss the foot with betadine and then with chlorhexidine, and then I put a glove over it and then another, like a sock. Jay, do you prep the foot?
We do.
Yeah.
We do prep the foot. Again, you see how aggressive this external rotation is? I don't like this.
There's one question here.
I think there's a pretty
Yeah, we do prep the foot. Foot was prepped. With the bilateral, we actually Yeah, for some reason, persona today has been a little aggressive with the external rotation. I don't like that too much. So I'm going to change.
Okay. There's a question, go ahead.
I think there's a pretty recent study from, I think, Andrea Baldini group about cooling down the skin prior to the start of the surgery to limit the inflammatory response. What do you think?
Yeah, that's
about
quite an interesting study. Jay, you know Andrea Baldini's study about cooling the limb before the surgery to reduce the inflammatory response. Do you have any views on that?
What does?
There's a study by Andrea Baldini showing that if you cool the limb before surgery, it can reduce inflammation.
If you pull?
Cool it. Bring the
Cool it.
temperature of
Oh.
the leg down.
No, I did not. I'm not aware of that. That's interesting.
Yeah, so that's it. And actually, it can be conversely have a potentially poor effect if you cool the whole patient, because we know that hypothermia is a massive risk factor for infection.
That's interesting. I've never heard of it. Have you heard of it? Cooling the leg before surgery.
No, I have no idea.
No, not many people know about that. So let's see. Jury's out on that. Let's carry
No,
on.
it's Baldini, the Italians. You know, they have too much money.
There's one question over there. Yes, there's a question from our colleagues from South Africa.
Yeah, I would just like to find out.
Go ahead.
Why
I'm
don't you
very
use,
listening.
A space suit.
Oh yes, he's asking about the use of spacesuits. Good question.
Yeah, perfect question. Thank you for asking that. I was hoping somebody would ask it today. So that's been discussed extensively, as you know. Yeah. The thinking is that spacesuits prevent infection, right? That's the reason we're using them, mostly. Although some people use it to prevent blood from splashing on their face. So it was discussed during the consensus. Gary Hooper, Simon Young, Atul Kamath, Mark Spengel, the best people that have done a lot of work on this, evaluated it, and believe it or not, there's actually nothing in the literature, including registry data, to show that the use of a spacesuit reduces infection rate.
And
On
in
the
fact,
contrary,
obviously, and in fact, if you use it incorrectly, so you don't tape your arms, etc., it can potentially drag air into your wound. Correct?
Ah, olsun. Evet, yes, exactly. That's exactly it. That's exactly the other problem, that if you don't use it, especially if that glove sleeve junction here is not covered, what happens is that you will blow the air down the arm and it'll come out of this area. So when I used to use it at Rothman, I used to seal this with the use of a IOBAN. The third reason is people reach out to the visor and touch it and bring their hands back into the wound. And we have done studies showing that that absolutely increases the risk.
Yeah. So they say the visor is supposed to be sterile, but actually we know that it does collect small microbes, etc. So touching the visor.
Then there is the
no-no.
economic as well as environmental cost, by the way, guys. I don't know.
Yeah.
Have you seen like how many bags we take out of the OR?
Definitely.
It's unbelievable. Posterior temple.
So what was the wear pattern like for this lady? Was it a varus, mainly medial and patellofemoral, and a little bit of lateral?
Nothing, just a gentle varus, nothing unusual. We'll show this. We'll show you the X-rays in a second. We'll show you the X-ray in a second. But
Okay.
yeah, varus, but try compartmental.
Any questions? No, not one question from.
So those are the APs. I don't know if can you see the X-rays or no?
Yes, yes, we can see that.
Yeah. So it's a straightforward.
Looks like a bit of avascular necrosis on the medial femoral condyle as well.
Yeah, she's had so many steroid injections, believe it or not. This lady is from Iran. Hi, Ranjor. This lady is from Iran, and she's had, you name it. There's some of the injections that I don't even know what they are, and
yeah, and I think
I don't
there
even
is
know her doctors knew what they are either when they were injecting her. But
some.
yeah, she's had
It's more of a problem as well in the hips, isn't it? We've seen a lot of AVN in multiple injections within the hip.
Test lütfen. Bir saniye.
Yeah, we can see those x-rays. So what are your routine pre-op radiographs that you get? Do you get any, you've got an AP, a lateral I can see here. Do you get
We
a,
get the 3 views, and then also we're very lucky here. Thanks to Professor Tozen, we have the EOS in the at Acıbadem. You guys know EOS?
everyone know EOS? The, no, there's a few shaking heads. Why didn't you?
EOS is the French technology that does a whole body radiograph, basically. So especially for the hips and stuff, very useful. So we have a lot of data on EOS. Bir saniye, lütfen. So here we've done the tibial cut, and now we're alignment rod.
You're just sizing and checking the alignment, correct?
So you know, there's a lot of alignment philosophies. The one that I like is called the unintended kinematic.
A little bit of
know what that
variance,
is?
not too much.
Yeah. Do you know what that is?
There's a lot of laughs. I think people understand in the.
Yeah, so if I show you the x-rays a little later and they don't look so great, I'm going to tell you that I did a kinematic alignment.
Very good, very good. I think the EOS machines were really good. It's expensive, but it's better than long leg X-rays because you don't have the magnification issue. We in our hospital you have to stitch the various X-rays together, and it can put things off. The best thing to do is to convince a spine surgeon that they need an EOS machine. Then they buy it, and then you can use it. So it's the best thing to do. Question.
Just the tibial cut,
Closer,
because most of the time it's easier because the leg is in varus or valgus, you have a defect. But just in case you see OA on both sides, but you cannot really make up in the operating room where is the most of the defect. What do you do? How do you do a cut on the tibia? Because I know from the persona you do 2 and you do 4.
Yeah.
So now, how do you get?
So you can do 2 or 10 on the persona. So if you're not sure and both sides are worn, it's better to go on the side of caution and maybe put the 2 on. Then you can go down with a couple of holes if you want to, a little bit further, and then you can recut. So if you take too much bone, you can't put it back. So I always go conservative.
Good job with this one.
So are you doing a PS here or a CR?
Yeah. I like knee designs that don't take out too much of the box. Ranjor. You see, the box cut here is basically so small. That's it. That's the box cut.
And it changes with the implant size, I think, for this system.
It does, yeah. But it's still very, very low. But people who don't like, people who, we can try the, people who don't like the PS, they say it's because it causes box fracture. And I think it can cause box fracture, but it's so rare that with the good design knees, you get that problem. We'll see if we cut enough tibia. I usually go back and revise the tibia.
This is what we were saying, that you don't want to take too much bone off. If you have to, you do another recut.
Okay. Düşmeyeyim.
They're asking whether you do medial release. I can't see. You did very minimal medial release, didn't you? I think for the... No, so you don't need to very much. So you will have to do some medial release, yeah. So I think at the moment there's not much evidence about PS versus CR versus MC. So there's a lot of talk about medial pivot, medial congruent knee. So I like that philosophy. I do kinematic alignment, unrestricted, but I think, you know,
It could be that
the jury's still out on all of these alignment techniques. You know, we still don't know where the knee should be. So, you know, we need to know where we should put the knee and then use something accurate to put it there. But at the moment, I feel that a lot of people are using technology to accurately put the knee somewhere that we don't know where they should be there or not.
That's revise. Okay. All right, let's do this. Let me see that Ranjor Lutfen.
Was that enough tibia, or are you going to go back to
It is
recut?
enough tibia, but I think
Some osteophytes at the back.
no, the trial, sometimes that screw is prominent, exactly. And sometimes the osteophytes in the back, they're preventing you. There's quite a bit of stuff here. Lamina spreader, Lutfen. So what we want to do is, we want to go back and look. She doesn't, as you can see from the x-ray, she doesn't really have too much of varus or osteophytes, but there is a piece of bone.
If you want to invest in one piece of equipment that's useful for all your knee surgeries, is a lamina spreader, in my opinion.
Yeah, so I've applied lamina spreader. I'm going to remove some of the meniscus that's in the way, and I feel the posterior condyle. That's good. Popliteus, nice and tight. No bone there. And now we will check the evet.
So there's something there.
There's a little bit of there is a bit of çekiş.
I saw it slip out, that little bit of bone.
So yeah, that's better now. Ranjor or Koher? Whichever. Evet, güzel. İyi.
There's not very much bleeding, is there, from what I see? I mean, I use a tourniquet, but looking at that, there's hardly very little bleeding.
Evet, lütfen. Evet, orada da bir
Who
şey
uses
var.
a tourniquet?
Femur lütfen.
At time of cementation. I think if you keep the pressure low, around 250 or at least 100 over the patient's blood pressure, it's fine. The days when people were using tourniquets of 350, of course the patient's going to have some quads weakness afterwards. But if you keep it low and the operation is not super long, it's worthwhile doing. I think it helps me see more, and then I take it down before the end, basically. Especially also for my PJI cases, allows me to do a big debridement, and then I take it down afterwards. But you could do either way. I've done it without. There's been studies.
We'll just go with the real.
And this Trolson convinced me to not use a tourniquet because of the studies, and then 2 years later he came back and said, actually, it doesn't make a difference. So,
I think it's the,
so I went back
the
again.
Screws? Do you see that screw? Those are sometimes the problem.
It depends.
So
If sometimes I do if it's an easy sort of a fairly lax knee, but often I just sublux it. Do you sublux the patella most of the time, Jay?
So we did no, I don't. I don't invert. I'm sorry. I sublux the patella.
Yeah.
I don't invert.
And this irrigation fluid that you've got attached to your to your wash. So where is it? Saline? Is it iodine injected in a saline bag or?
So we are going to put the other trial. Sometimes we çekişin impactor. Sometimes this doesn't. The trial sometimes does not sit properly.
That looks fine, doesn't it?
And the poly. Teşekkürler.
What size poly is that?
That's a 10.
Okay.
Butti. Allah, Allah, Allah. So we do the airplane test. Do you remember this, Upton?
Yeah.
This is Bob Booth's. This guy, Bob Booth had a bigger belly than I do, but it's called an airplane test. So the knee should not come out to flexion. If it does, that means you're not in full extension. Shock test. You should not hear the components move when you do this. Then obviously you feel. And then mid-flexion, we test for movement. There's none. And I know you're not going to believe me, but I'm going to have Professor Tunchai also test in a second. Goes all the way to flexion. You should not see the poly lift off.
Yeah.
Or protrude.
And the patella is tracking nicely, I can see.
Yeah, so I have, patella. I resurface the patella. Not everyone. Clamp lütfen. I clamp patella. I measure the patella before we start.
Can I have a question?
Yes, there's a question.
What's your goal of laxity? Do you prefer some more laxity in flexion on the lateral side, or?
It's fine.
It depends on the knee system you use. So with this system, you've got to be fairly tight. I think with the medial pivot knees, you can't put them in too tight because they get stiff. Jay, do you like to have the knee a bit lax, or do you want to keep it tight? That was the question.
Well, do I have to what?
The question was, go ahead, ask.
So what's your goal of laxity? How lax would you like your knees? And whether you want some laxity on the lateral side, some more laxity than on the medial side.
So I didn't hear it. I'm so sorry.
Do you like to have a bit of laxity on the lateral side? I said it depends on the knee design, but
I know. It's interesting. We can talk about that, and I'll tell you the Paul Lotke's study. That's very interesting. So we're resurfacing the patella. We noticed we don't take much of that patellar fat pad. We leave the fat pad.
Yeah, I noticed
That's
that.
very important for tracking. It's important for vascular supply. This is a brand new saw, and I'm not going to go through 15 times because then you can cause heat necrosis. We do irrigate everything before we cut. So again, this will just be irrigation. And then it measured 24 millimeters. So this is at 8 millimeter. We reproduce the thickness naturally.
Yeah, so I use a new saw blade as well for the patella to make sure you get one pass through. Minimum thickness of the patella, you try and keep back 14?
24, so we go down to 14, and we put a 10 back.
Yeah.
Now, it's interesting, you can actually feel this. I'm feeling that I'm a little thick inferiorly. So what I will do is I will just go back and very gently, test it out. Very gently, I will just revise this a little bit. That's it. That was a 35. 35. Feels much better.
Who resurfaces the patella here routinely? I do now. I started doing selective, and then I've gone to routinely doing it. I think the evidence will allow you to do either, to be honest. In the Middle East, I think we don't resurface a lot of patellas because of fracture risk and praying. Is that right?
So, Afton, I don't know if you and I wrote this paper. I think it may have been. There's something called the vertical patellar sign. Yeah. Can you guys all see it? You should be able to hold the patella vertical.
Just move your right hand for me. Just move your right hand. Thanks very much. Yeah, we can see
how
that.
This is held so easily, and it's not at all tense. The other thing is that the most lateral point of the patella should touch the medial condyle, like this. You see that?
Yeah.
Then that means it's going to track. It's a little tight. So because we don't use the tourniquet, there's some bleeding.
In extraction.
Yes. So throughout we've been using povidone iodine. In a second, you will see we use the Molnike's irrigation solution. Çıkardım. Yeah, so we are going to remove.
Yeah, you can. He's going to do there was a question here about tranexamic acid IV versus topical. I said the evidence is you can do either as long as you put at least 1 to 3 grams during the operation. I do one IV at the beginning, one IV at the end. Some of my colleagues do IV at the beginning, then intra-articular at the end. So. And then they do 5 days of oral, which is really good. I tried to do that in my hospital, but got told off by the pharmacist because it's not off-label, but it does reduce your inflammation and post-op bleeding, and also reduces the need for pain relief. Yes, go ahead, sorry.
This is the Molnike's irrigation solution.
Granulation, yeah?
Granulation. We pour that in. I know you're not supposed to leave it in for too long. You don't need to, but I do actually just pour that in and wait for a minute. At this point, they're opening the implants, and we are going to be, in a second, changing our gloves. And basically, the knee has come into contact with povidone iodine, obviously hypochlorite. And this way, we have hopefully removed all the contamination before we bring the implants out and start to cement. I use cemented knees. I haven't done any uncemented. We can talk about that philosophy later, but honestly, it doesn't matter. Your infection prevention protocol should be the same anyhow. So that's it.
Yeah, so I think you can put the most expensive uncemented knee in the most expensive alignment. If you don't get the patient's HbA1c correct before the surgery and they get an infection, it's all gone to waste. So people used to focus a lot on the implant and the technique of actually doing the surgery, but actually it's everything around that determines how successful you are. It's a very forgiving operation, but people just forget the before and after and the perioperative period. So glove change routinely at least twice during the surgery, more if you're doing revision surgery, correct, Jay?
Evet, we change and we wash. We're constantly washing before we do. And then I'm going to just look at the tibia one more time before we cement. I wasn't excessively happy with it. It felt a little too tight, so I might just touch the tibia one more time. Evet. Just it.
Benim elimde bir tampon alabilir miyim? Bir altta.
Little bit of Michelangelo artistry, yeah?
I love revising cuts if I'm not happy with the tightness, etc. Again, we watch. If you notice, nobody puts their hand in the wound. We try to avoid touching the wound, especially after we've done Ranjor.
The irrigation.
And honestly, I think you can just basically get away with not having to do femurdan başlıyoruz. Evet.
Yeah, you have to curb the enthusiasm of your colleagues if they want to put their hands in. So everyone tries to be helpful, but I think no one should put their hand in the wound. There's another question here.
Exactly. You have to remember that this is. You have to remember that your gloves are contaminated. Even fresh gloves are contaminated. So.
Go ahead.
Yes.
You can put a bone plug here. Sometimes we do. Or you can use cement. I prefer Ranjor. And now, if you noticed, we didn't do too much exposure here, up there. You know, if you take too much of this periosteal
synovium
layer,
yeah.
I think you can get others. You can get, perfect. We dried, and now, mhm. Çek geçir lütfen.
Çimento kazıcı. Çimento kazıcı.
So we try not to remove too much of that periosteum. It causes, I think it can cause extensor mechanism tethering. It can cause periosteal elevation, periosteal
Reaction, yeah.
hypertrophy and reaction and all that stuff. Perfect.
So you put the femur in first, but you can do tibia as well, right?
I like to make my life miserable. Evet, evet. Bir saniye.
Good.
I see he doesn't use peroxide. Do you use peroxide?
Hydrogen, I'll tell you my view. We're not allowed to use it in the UK because of risk of air embolism, but there are countries in Europe who use hydrogen peroxide. There was a question about hydrogen peroxide as an irrigation fluid, Jay.
No, not in primaries. Not in primaries.
Not as irrigation.
Not a good idea.
Not as irrigation.
Hydrogen peroxide is cytotoxic. That's number one.
Not
Secondly,
just to
not even for drying, no.
There have been episodes of air embolization with hydrogen peroxide. In a primary, I think that's too much risk. I wouldn't.
Some countries do.
Yeah,
That's interesting
Just to
because
dry the wound.
I haven't seen a patient with
Statistics. If you do enough, you'll see. So we've definitely had quite a few in the UK.
Yeah, so we don't use it. Oh, it's not good. Yeah, we don't use it in a primary. No way. And we don't add it to. I know Brian Springer published a paper showing it was more effective when combined with the pelvic iodine.
I think there's so many other good irrigation fluid options available that probably it's not worth risking it, to be honest.
So we're exposing to make sure we get all the cement out.
Is that antibiotic-loaded cement or?
No, we don't use it. And there's multiple reasons for it. Again, there's no data to prove that's the case. And I know you come from England. A lot of people say, what about the British Registry? I'll say, what about the British Registry? They haven't really... You know, if you look at the British Registry, the signal, 98% or 97% received antibiotic-impregnated cement, versus 3% didn't. And those 3% had allergic reaction to antibiotic. That's probably why they didn't receive it in the first place. So it is really, the antibiotic-impregnated cement is not...
It's neither here or there. And that's E-poly you've got there?
That's E-poly, yes. And now we keep it in extension, and while the cement is hardening, we will, Patella, lütfen.
So I see quite a lot of irrigation going on here. You see, people underestimate the amount of irrigation you've got to use during the surgery because there's a lot of debris as well. All the bone that is in the knee can cause synovitis as well.
You know, a lot of people wait until the end to do the irrigation. I think irrigation should be done throughout the procedure.
Yeah, same. So do you use one mix of cement or is there two mixes going on there?
Two mixes. We have a lot of money here in Acıbadem.
Absent, can I ask?
Bonjour.
Loud.
No, one is not enough. We usually find one is not enough.
Sure. There's a question here.
That irrigation that's being used, is it basically a big bag with iodine in it?
Yeah, I know it is, but Jay can tell us. Jay, your irrigation fluid, you've got a big bag of saline and you inject iodine into it, or?
Yes, so unfortunately, we don't have sterile povidone-iodine irrigation solution available in Turkey yet. Those are the ones that come in bottle. So this comes out to extension. Do you see this? And at this point, I'm waiting for cement to harden, and then we will, either myself or Professor Tunchai will check the patellar tracking. And the gentleman here, the two young, handsome, Muzaffar, he's the drummer. Oh, no, you're not the drummer. You're the guitarist. No, drummer. Kayahan is the drummer, real drummer, and Muzaffar. And we have Osman. We have Osman from Zimmer Biomed. He helped with the surgery. And then we have Yorsun, Yashin, Yeliz Hanım. You see, she's fantastic. She knows exactly what we're doing. These people make us look good during surgery. You all know. And when people have visitors and live surgeries, things can go wrong, but their steps are like meticulous. It's a very beautiful OR. We have laminar flow, as you can see here. You don't have to have a laminar flow, but you need a positive ventilation system, as you all know. And then we also minimize OR traffic. The door shuts. There is a sign outside that arthroplasty in progress, do not go in. Our circulators are fantastic. They only go out and come back and when they are absolutely, when it's absolutely necessary.
Yeah, we
So
looked
limit
at that,
OR
didn't we,
traffic.
when I was in Rothman with the door openings and the particle counts in theatres.
Yeah, so you can imagine that OR traffic. So if you think about the source of microbes that cause infection, they come from three sources. One, patient's own microbiota, skin, nose, oral cavity, the joint itself, and the gut. So let's talk about that very quickly. Skin, you asked me about what we do. We do preoperative antiseptic soap or antiseptic wipes. We actually give them those hand brushes, chlorhexidine?
Yeah.
We give them 2 of those and ask them to use one 48 hours and the other 24 hours before surgery.
Sure.
On the day of surgery, we also wipe the skin with chlorhexidine, povidone iodine, and 2 rounds of alcohol. So that's for the skin. Skin has 1 million microbes per square centimeter. So to remove those microbes is essential. Nose, we do nasal decolonization, antiseptic, not antibiotic.
Yeah.
Antibiotic has issues, resistance, 7 days of application, patients don't know how to apply, et cetera, et cetera. 3, oral cavity, we don't do this, but I think it might be a good idea to give them an oral cleansing agent. And of course, we look at their teeth. If there's evidence of oral disease, we send them to dentist, but we don't do routine dental screening.
Yeah.
The gut is an interesting area. So the surgeon that asked about GLP-1 agonists, that's an interesting concept because as you know, Apton, and as you mentioned, GLP-1 may have some anti-inflammatory properties, probiotics, administration of prebiotics. That's coming out of Australia. The Bupi's work that we're about to publish, the prebiotic administration changed the gut microbiota. So that's patient's microbiome. And of course, the joint itself has microbiome. That's why we irrigate. We cut the skin, povidone iodine. Arthrotomy, povidone iodine irrigation. Then guanidine. So basically, you're continuously washing and trying to remove the microbiota of the joint. So that's source 1, patient's own microbiome. 90% of surgical site infections come from patients' own microbiota. Number 2, droplets in the room air. So we have the ventilation system that hopefully is removing these particles, but droplets in room air come from people. We shed 10,000 microbes per minute. At the moment in the OR, there's too many people. We usually don't have this many people in the OR. So if you think about a surgery that takes 1 hour and you have 10 people, that's a lot of microbes that people are releasing into the room air. So you need to have a good ventilation system, reduce the number of people in the OR, reduce OR traffic. The third is contamination of instruments, implants. So instruments, they get cleaned here. We have a very, very strict protocol in the sterile processing unit, no flashing, and the orthopedic instruments get processed differently than others like gynecology or plastic surgery. And the implant, we try not to touch them, especially in the hip. You can really get away without touching them. Unfortunately, in the knee, not so easy. And then as you saw, every time we touch them, we are irrigating them continuously. And our hands are also a source of contamination. So if I were to stick my gloves into an agar plate now, I guarantee you it will grow some organisms. Maybe Siacne, maybe Staph aureus. So that's why we try not to bring our hands into the wound, particularly with continuous contact with these soft tissues.
So
Those are
in summary, we can't ever sterilize the wound ever. It's just making sure we tip the balance to our favor, correct?
Exactly. All you're doing is providing a clean environment. There is like absolutely no sterile wound. And as you know, we've shown, and I know you talk about this also, if the bioburden is above the immune threshold of the host, there will be an infection. If bioburden is below the immune threshold of the host, then there's no infection.
Yeah.
So we try to raise this bar, a better glycemic control, metabolic syndrome, anemia, better nutrition, etc. So to raise the immune threshold of the host, and we try to lower this one by irrigating continuously, by cleansing the skin, by doing expeditious surgery, by administering antibiotics, etc., etc. So we're trying to tilt the balance in favor of the patient. So the great question that Chris asked earlier, it's a philosophical question, because if you tell a patient that your BMI is 41 and I'm not going to operate on you, or if you've got, you're smoking too much, I'm not going to operate on you, et cetera, we can never remove these even modifiable factors either, but we should try to reduce the risk as much as possible. So that's basically an overall concept. So on the preoperative side, the other three things I did not mention, which might be worthwhile: anemia. Anemia is a terrible problem. It increases all-time mortality, increases length of stay, and increases the risk for cardiovascular events, and of course increases the risk for infection. So if
Hang on, Jay. If you can hear us, you've just cut out. We're going to try and get back in here. So I think you're going to see, whilst we're waiting to get back on, there's my talk is going to have a summary of all the things we've just heard about, with some of the evidence as well. So it's not just one single silver bullet that's going to stop you getting an infection or treating an infection. It has to be sort of a stepwise process with marginal gains, essentially. Does anyone do anything different?
Recording in progress.
And of
we're
course,
back.
tranexamic acid. So on the tranexamic acid, I may not have
Jay?
been part of the conversation. Tranexamic acid you can give intravenously, 15 milligram per kilogram, 20 minutes prior to incision. You can repeat the dose if you want, but the results of studies are a little mixed. The repeat dose doesn't seem to be so much protective. Oral, we like to give it because it reduces ecchymosis and swelling. You can give it topically, but topically you have to triple the dose. So if you were given 1 gram intravenously, now you have to give 3 gram topically. You can inject into the joint after you're done, intra-articular. We haven't done it here. Has anybody in your group in the room have had experience with intra-articular tranexamic acid?
Who injects intra-articular? One person. I mean, you can do that. Some of my colleagues do. I personally don't. I'd rather give it all IV and oral, basically.
Are you asleep, Apton?
Pardon?
Did we lose you?
No, I'm here.
Okay, perfect.
We lost you for a bit, but you're back. We heard the most important thing about tranexamic acid. We missed a little bit about the anemia. If someone's anemic, What do you have a protocol for investigating the anemia and optimizing it? Do you give IV iron, EPO? We missed that.
Oh, I'm so sorry. Yeah. So as an orthopedic surgeon, you can actually determine the cause of anemia very quickly yourself. Look at hemoglobin, lower than 12 for females, lower than 14 for males, they're anemic. Look at MCV. MCV is low, they have microcytic anemia. Iron deficiency is the main cause. MCV is high, they have macrocytic anemia, B12, B6, and folate deficiency. MCV is normal, but hemoglobin is low. They have normocytic and normochromic anemia. You could also look at MCVH, etc. But so chronic diseases like liver disease, kidney disease, malnutrition, blah, blah, oh, they could cause a normocytic anemia. Those are challenging. But microcytic, yes, give IV doses of iron. Macrocytic, put them on vitamin supplements. But we usually send them to a hematologist to evaluate anemia. And we try not to operate on them if we can. And then we talked about tranexamic acid.
And
I
what's
think I may have lost you.
your thoughts about blood transfusions post-op and their effect on the immune system?
Yeah, very, very solid data shows that allogeneic blood transfusion increases the risk for infection, venous thromboembolism, cardiovascular events, and increases mortality. So you should try to avoid and of course, by reducing immunomodulation, by causing it can cause other types of immune-related issues. So we try to minimize allogeneic blood transfusion. We don't have a hemoglobin trigger. Do you have a hemoglobin trigger in Oxford?
No, we go by the symptoms. We try as little as we can to transfuse the patients for those reasons that you mentioned. And I think that's another reason to start to talk about anticoagulation and things that might make you bleed more. What do you use for anticoagulation?
Well, we use aspirin. I know that a lot of you in Europe can't use aspirin because of the regulations and guidelines, etc. Hopefully they will change in due course. But you could give 7 days of an aggressive anticoagulation, if you like, something like low molecular weight heparin or factor 10 inhibitors, and then switch them from the aggressive anticoagulation to aspirin, because the risk of VTE is really the highest within the first 72 hours, maybe extended to 1 week. It doesn't mean it can't happen after 1 week, but the risk is really, really low. So maybe during the first 7 days, you could use an aggressive anticoagulation and then switch them to oral anticoagulation. Like the Michael Dunbar study that was published in New England Journal of Medicine about a year ago or so. So they gave rivaroxaban for 4 weeks.
Yeah.
Rivaroxaban for 1 week and then aspirin for 3 weeks. There was no difference in VTE events. That's the New England Journal of Medicine paper. Now their follow-up studies, rivaroxaban 4 weeks, aspirin 4 weeks, no difference.
But if you have the choice, you'd like to try and avoid aggressive anticoagulation, correct?
Yeah, I mean, in a patient like this, people say bilateral, really high risk, but you know, she will be walking in 2 hours. We are constantly ambulating our patients. We didn't use tourniquet. We didn't lose too much blood. There's not going to be too much problem with swelling. She will be ambulating. We use TED stockings. I like to give her aspirin, but a lot of people feel that, you know, they have to give something aggressive. The problem is if you give something aggressive, she's likely to develop a hematoma, and then you've got a major problem. And she develops an infection in the joint. It's a big deal, as you know. So, yeah, aspirin for 4 weeks.
Same. Okay. Any more questions? Wound closure. So we said triclosan coated sutures, barb sutures.
Yes, we're using barb sutures. And then we use, so we use barb suture for the arthrotomy. And now they're using, again, the plus sutures. We do the closure in layers, like you would. We do use monofilament suture to the skin. We don't use glue. We don't use Steri-strips. And then we apply occlusive dressing.
Yeah.
But in here, I'm also going to show you one of other beautiful products that Mölnlycke has that we like to use here quite frequently. Is the negative pressure wound therapy. And I know you've done a lot of work yourself on this, Apton. We could talk about it in detail. Honestly, does she need it? No, she doesn't. She's got very healthy skin. It's a routine primary. There was no issues with soft tissues. So she probably doesn't need it. But some patients undergoing primary are still a candidate for negative pressure wound therapy. And I use negative pressure wound therapy for all revisions, regardless. All revisions.
Same here, same here.
Yeah, and then some primaries. And we can talk about, I mean, in your opinion, you've done more work than anybody on this, and you probably know the answer, but who do you think, in your opinion, is a candidate for wound-related issues, and you would use a negative pressure wound therapy right off the bat?
Yeah, so again, for me, all revisions, all DARE procedures or periprosthetic fractures, and then you can try and stratify for your primaries, for your complex primaries, in terms of usually more than 2 comorbidities, so aggressive anticoagulation, diabetes, smoker, rheumatoid disease. Mölnlycke have a nice chart that gives you a traffic light system of green, yellow, and red to say who might be a good candidate so that you can justify the use of it, because obviously there's a balance to be said.
Yeah, I think that's that's a very interesting area. It's evolving. It's a fantastic product. I mean, and I know a lot of companies have them. Mölnlycke is not the only one. And regardless of which one you use, I think negative pressure wound therapy certainly is a very, very good product that can prevent wound-related issues before they happen. And once you have persistent wound drainage, it could be that patient is in trouble at that point. So preventing that from happening is a very, very good idea, in my opinion.
That's right. And I think, as you said, the SafeTac technology for Advanced Solo prevents some of the blistering that we sometimes see with some of the other systems. Do you agree?
Absolutely.
So it's a bit more gentler to the skin. So that's probably one reason to adopt it. There's a question here. Yes, sir.
Yes. I've seen when they are closing the wound.
Yes.
What does it do for pain control afterward? Does it give any local injection?
Do you give any Lear? So what's in your Lear? I know what's in your Lear, but tell us.
Yes, I'm sorry. Yes. Kayhan and Muzaffer, they just did it, actually. You gave the local anesthetic injection already. Yes. Yeah. So what is in our Lear? I never know. They make the concussion. Like they make my cocktails. But so we have obviously local anesthetic, bupivacaine, right? We have antibiotics, and then we have we have dexamethasone, 8 milligram.
I think in
8
this
milligram
in this region you call it the Ranavat concoction, don't you? They used to call it by that, the Ranavat solution, which is corticosteroids, antibiotics, local anesthetic mixture. We just use local anesthetic and adrenaline in our hospital. We've moved away from corticosteroids, but I think you do use that.
Okay, so they just closed, and now as they're peeling off this is very important step, by the way, very important step. As you peel off that incised draping, underneath it, this area now is really rich in microbes, really rich. So they will not touch it, and they will sterilize it with the use of povidone iodine. Did you see that?
That's right. I do the same, and I.
Very, very important step. And by the way, during surgery, if you see that incised draping, the eye band lifts off, you must use povidone iodine to try to sterilize that region.
Yeah.
And they're very gentle. They're using non-teeth forceps. They're not grabbing the skin edges. And they try to just gently tighten the sutures, not strangulate the soft tissues. We try to do, obviously, watertight closure, very important. And as you see, this is done in like semi-flexion for the knees, very important. Direct anterior approach. We also try to use occlusive dressing. Here we were going to show you Avant Solo. We have one in the room. And the team here is very familiar with the use of negative pressure wound therapy. And they will, once the wound is closed, they will use it. So that's like our soft tissue. We don't use a drain. Anybody in the room is still using a drain?
Anyone use a drain for primaries? There's one culprit here. I'll sort him out at the break. Don't worry. There's a question here from Poland.
Yes, I'm coming back to the topic of local anesthesia.
Yes.
Do you just put it directly into the knee, or you just do the injections near the genicular nerves?
So there's a question about local anesthetic, the technique.
I got it. Yeah, we use it directly into the soft tissues, and we also inject into the adductor canal ourselves.
During the surgery, you do a surgical adductor block.
And we also have a fantastic anesthesia team that can do an adductor block under ultrasound post-op. Sometimes we do that for complex revisions, etc. But injection, that's a great question. So injection is into the soft tissues, including posterior capsule. I'm sorry that you missed that step, but we had 20 cc of the local cocktail that we inject, but we also inject it into the adductor canal. And it's very easy to inject into adductor canal. I haven't done it myself. These guys do it.
Yeah, we use something similar. We do adductor block at the beginning of the case, and then when I start, before making my bone cuts, I do a sort of a ring block around the femur and the synovium of the femur, and then you can see it on the vitals. Their heart rate does stay down once you start the cuts, and then I do at the end into the posterior capsule and the soft tissues like you saw here.
So this patient is having surgery under combined anesthesia, epidural and the spinal. We prefer that. Regional anesthesia is our preference. But if you did general anesthesia, especially for both knees, I think it's critical that you do LEA plus adductor canal.
And that allows you to get them up on the day, right?
Yeah, and also, obviously, pain control is down, and adductor canal seems to spare the motor function to a large extent. I've seen some motor block. But if you're doing femoral block, for example, they do get some extensor issue, and we've seen people fall. So this patient will be up and walking within a few minutes, a few hours of the surgery. So we don't want to get any motor block in these patients.
And she'll be full weight bearing.
She'll be full weight bearing because it's cemented prosthesis. Even our hips that are uncemented are also fully weight bearing. Very rarely, if we're worried about bone density and patients are really, really obese, we will use a mini stem.
Yeah, stubby stem.
Stubby stem in these knees. I think tibia is at risk, obviously. On the osteopenic, osteoporotic, we're extremely careful about notching. Very, very careful about notching. So, yeah, I mean, all the knees are pretty much fully weight bearing.
Okay, so we're just waiting for the advanced solo dressing to go on.
Yep, they're coming to the end of the surgery now. So one question I would like to ask the crowd in that room, how many of you are still using staples to close the wound?
There is, it's about 50% of the room.
Oh, is that right?
Yeah.
Wow. Yeah.
We got some work to do.
Well, what do you do yourself, Apton? Do you use staples?
No, I moved from staples around 3 years ago. I think there's slightly more higher infection rate, but most importantly, if you ever had to take staples out of a patient, you'll never put staples back in again. So I watched one of my favorite patients who I'd known for a long time, and I wanted to take the staples out myself. And by the time I'd finished, she was in such tears, and I said to myself, I'm not doing that again. But I think there's good evidence to show that subcuticular sutures, the sort of perfusion around the wound edges, they've done sort of finite element studies, is reduced. Is that right? Or infrared studies?
Yeah. I mean, Robert Truesdale's work from Mayo, they showed better
Perfusion.
vascular supply. In the general surgery, they've done those. Look, staples are convenient. They're faster. But that's it. Maybe they're cheaper, I think. Maybe. I'm not sure, though. They may not be. But the disadvantages of staples is, one, removing them requires a patient visit, and it is painful sometimes, especially if they're stuck in the soft tissues. Leaves that ugly rail track mark. And if you're using staples, you've got to really, really get those wound edges nicely opposed. If you don't, and there's an inverted wound edge under staple, that's the source of persistent wound drainage, etc.
That's right.
So, and I don't really think with the staples you can get watertight closure, at least not superficial tissues. But again, those are my personal opinions.
What
Please,
about glue? What about glue?
yeah, we don't use it for various reasons. Number one, I think you really don't need it. If you're doing a beautiful closure like these guys are doing, glue is not needed. The second problem with glue has been the aggressive hypersensitivity, especially with one brand of glue, the cyanoacrylate that we've seen. So we don't use glue. We just stick to the use of occlusive dressing.
I started using glue about 5 years ago, and then I had quite a few glue reactions. It happens more in high tension wounds like knees and elbows, and also with people with dark skin. So in the Middle East or Africa, where there appears to be that skin reaction happens more in patients with dark skin. So just be aware of that.
And you know, if you use glue, you can still use negative pressure wound therapy.
Exactly.
A lot of people think that you can't. You can still use it, and you can, of course, use occlusive dressing, because negative pressure wound therapy works differently. So you can certainly do that, but we just don't use glue.
Yeah, we got a question at the back.
Hi, Giulio from Italy. I was wondering, since you don't use staples, you use just sutures. Do you always do continuous suture if you want to have like a watertight closure? And do you use it also in revision cases? Because I would be scared as hell to use a continuous suture in revision cases.
Yes,
I'm
great
just
question.
wondering what's your habits.
Good question. Go, Jay. You go first.
Yeah, perfect. So yes, we use for the arthrotomy. Let's talk about the layers. Arthrotomy, we use barbed suture, which is obviously continuous. For the subcutaneous, you may not have seen it, that's interrupted. Subcuticular is also continuous with a monofilament suture. Yes, we use the same closure for primaries as we do for revisions.
Same. So I do.
There are circumstances where we deviate from that protocol. If the soft tissues were very, very poor, if the soft tissue dissection was extensive, if there were issues intraoperatively, etc., we are prepared to deviate from that protocol if need be.
Yeah, and I think in the odd case you might, but actually for those poor wounds during the revisions, you want actually the gentlest way to close the skin rather than the clip. So I've moved to doing, again, the same closure for all my knees and hips, and we do the same across our group. And if you're worried about the wound, keep them in extension in a cricket pad splint, like a Don Joy brace, and stop them from bending for 5 days, and that will allow the tissues to calm down, and then you can gently get them going. And then obviously, if you're worried about that, you can put a negative pressure dressing that stabilizes the wound edges and reduces your dehiscence rate as well. So those are the things I do rather than use a clip. So I moved away from clips, and I use barb sutures for all the layers. So the barb suture that you use, a 3.0 Stratafix, is basically a monofilament. It's the same as a nylon, so you could use it in the skin. Question.
Hi, I know you mentioned before when we were putting on the Meplex border post-op with the first knee, you did talk about kind of undisturbed wound healing. I'm just wondering, I still know of a fair few clinicians who are very keen to visualize that incision as sort of a matter of habit before we would necessarily recommend removing the dressing, and same with negative pressure. I just wondered what you might say to that and kind of in that context.
Yeah, so I'll give you my opinion about that first. So originally, when this wound review came into contact, was because all dressings only had a 7-day license, and so they were all predicates of each other, and so someone who made a new dressing could only license it for 7 days. I prefer for the wound not to be looked at for as long as possible, for up to about 14 days. So if I can help it, I tell them not to have the wound disturbed for at least 10 to 14 days, and then look at it at 10 to 14 days. Because the one you put in here in theatre is the cleanest wound you're ever going to get. The minute you take off that dressing on the wall, whatever you do, it will become contaminated. So best thing to do is to not remove it. Obviously, if you're worried about skin necrosis in a difficult case, you want the plastic surgeons to have a look, you can take it off. But if you can, you should keep it on as long as possible. With the advanced solo, the canisters for 14 days, but the dressing's supposed to be for 7, but I ignore that. I keep the whole dressing on for 14 days. And
Upton,
go ahead.
I bought this thing from Istanbul Bazaar yesterday.
I got it, yeah.
It was a special discount. So this is the box where this comes. This is a negative pressure wound therapy that has 3 attributes that are important, in my opinion. Number 1 is the pressure. Pressure is 125 millimeter of mercury. Not all negative pressure wound therapies have the same pressure. And you should know when you're applying one what the pressure is. Number 2, this has a canister. Granted, not a massive one, but there is a canister. And I think canister can fulfill a very important role. For some serious drainage, it's important to know if we're getting serious drainage or not. And then the third is that this is really lightweight and very convenient for the patients, because some of these negative pressure wound therapy are really bulky, and it sort of puts a lot of weight on the patient, etc. So we have our one. Oh yeah, the multi-layer dressing, of course. I forgot about that. Yeah. Yeah, so multi-layer dressing is very, very unique. Thank you so much. Multi-layer dressing, if it gets saturated, it will then pass the fluid to the canister. Because of a technology called controlled fluid management. How am I doing? Good? Yes, so far they think I'm doing good. So that's the dressing. Do you see that?
Yes, we can see that. Looks great.
So we're going to apply this in a second. And application of not just this, but all negative pressure wound therapy requires a little bit of skill and experience. If you don't apply it properly, and there are kinks and things, then you can leak. The pressure can leak and cause issue for the patient. And then 2, sometimes blistering that's seen with the negative pressure wound therapy, I think, in my opinion, is the way it was applied. If you apply under so much tension, it could potentially cause blistering. So we apply, and then we have reinforcement strip here that are very important. Oh, not here. My God, it's in here, yeah?
That's the patient guide in about 100 languages.
Yes.
Is that right?
And this also comes with the SafeTac technology that you mentioned earlier, Upton. And it also comes with a nice encyclopedia that you can read over a couple of years.
Yes, we see that.
Yeah, yeah. I'm gonna read this, so I'll see you guys this evening. All right. Any questions on the negative pressure wound therapy?
Any questions?
Oh, it does come with batteries.
Yes.
Lithium batteries.
One question from John. Where is he?
Applications for 7 days or for 10 days? yeah, so you can change the dressing.
John,
Yeah, and that's the
anything
other good
about
thing.
negative pressure dressing that we need to say?
Okay,
It's
they're
just
ready.
a quick comment from John Timmins from Molnica.
Do you guys want to see application? Yeah, let's focus on the wound. And
So
you
yeah,
can-
let's look at the application.
Yeah, I
So
love them.
you can see he's putting it on in flexion. So if you put it on in flexion, then it allows the knee to bend a bit more. If you put them on negative pressure dressings in extension, once they bend, they can shear the skin and you can get blistering. So make sure you do that. And then we've got Muzaffar. Go ahead. We're all watching.
That's
So
the
you got
strips.
the main dressing there, you can see, and then there are the
That's the main dress-
reinforcement
that's the
strips
main-
on the side.
yeah. Main dressing, and they also have the reinforcement if necessary. Yes.
So you can see here, he's just laying it on. He's not really stretching it, yeah? Because otherwise you'll end up getting shearing of the skin. So you just want to lay it on, no tension. And that looks good.
Ah.
There we go, and that's the canister. And then they're going to put some reinforcements on. Perfect. Jay, that looks good. I think if there's no more questions, we're going to move on to a coffee break. We wanted to thank all of you guys in theatres and also the AV team who've been great. The pictures were coming in nicely and the sound was excellent. So any closing remarks from you or Dr. Tunchai?
No. Dr. Tunchai is down there, huh?
Is he here? Oh, he's coming here soon. Okay, so we'll see you soon after the break, okay?
See you guys in a minute. Thank you so much.
Thanks very
Bye-bye.
much.
Teşekkürler. Thank you so much. Çok güzel. Çok iyi. Perfect. Perfect. Perfect.
Steriwave about nasal decolonization. So there is a new product that uses infrared beam to decolonize your nasal flora. So and then you don't need to have the chemical decolonization. Why don't you just give us a couple of words on those, and then we can go to break. Thanks.
Hi everyone. Just a quick word from Sinead. The Meplex Border Post-Op AG is only available in the US and South Africa, I believe. Yeah, so just if you are looking for that, we don't have it in Europe or Middle East at the moment. Yeah, just regular post-op, which is also very good. Of course, I'm looking at Chris now, who does like it, thankfully. But yeah, with regards to Steriwave, Steriwave is a nasal decolonization technology which we are working with at the moment, and it's essentially you can basically do both nostrils. It takes about 2 minutes per nostril, so you can use it on patients. It obviously doesn't have the same issues with antimicrobial resistance as mupirocin and things, so it doesn't need to be done in advance of surgery. You can do it just straight before surgery. You can also decontaminate the team who are going into theatre as well, which is also helpful. I think, Chris, you mentioned you have a couple of devices, do you, in Glasgow? Yeah. Haven't started using it yet. Yeah. Yeah. Yeah. So it's just something to think about. It's definitely on the horizon, and I think it simplifies decolonization for you guys, especially if patients are being relied upon to do decolonization before they come for surgery. If they've got a week of pirocin, how many of them are actually doing it for a week? So again, it's something else to think about. With regards the negative pressure there, just to finish off, like what we tend to recommend, of course, when you've got a gravitational issue, it's a lower limb wound, we would recommend putting the port north, so you put it in the upper aspect as they did. The other thing we would do is, like when you're switching on the device, we would usually not put the fixation strips on until you've got a seal. So put them on after you've got the seal, so you can make sure you've get any wrinkles out of the dressing. And then finally, Abden mentioned granulation, and you saw some granulation being applied during surgery there earlier. Granulation is our irrigation solution. And essentially, it's a hypochlorous solution. It's quite a low concentration of hypochlorous, so it's not super powerful as an antimicrobial, and I'll hold my hands up to that. But the reason that it's designed like it is because it's got a really low cytotoxicity, so it doesn't kill off our own cells in terms of fibroblasts and things like that. So what it does do is kind of preserve our tissue. So what you tend to get, I think, is a good combination of a mild antimicrobial action, but also with a really good irrigation action. But the key component for me for granulation is that it doesn't destroy our own tissue. So from that perspective, we're seeing lots and lots of benefits. There's lots of studies ongoing at the moment. We've just finished one with a vascular surgeon in Germany, and what they compared with saline. Unfortunately, when they powered the study, they'd had
Recording stopped.
They'd had a 12% infection rate prior to the study, so they chose 500 patients to do the study on, which was powered enough. But when they finished the study, their overall infection rate came down to 8%, so which was great. And the infection rate with granulation was about 4.9% versus 8% with saline. So we're seeing a big difference in terms of the overall infection rate, but not statistically significant. But what the surgeon said afterwards, he did feel that granulation definitely helped from a tissue preservation point of view. So it's something to think about.
That's a very important point, because you can always kill biofilm and bacteria if you use a strong enough solution. So you can put 15% betadine into a wound, it'll kill everything, including the fibroblasts and everything else, and then the wound won't heal. So there's a balance, and I think dilute betadine, granidacin, those are strong enough to kill most of the bugs, but not toxic enough or cytotoxic to allow wound healing.
Thank you. It's time for coffee. Great.
Right, enjoy the coffee, everyone. Thank you.
Yeah, no problem. Okay, yeah. Great, really good. Yeah, I really liked it. I really liked the idea of like all those things that you said. So, like,